Hello class, welcome to week 1 of KIN 264 Movement Anatomy. My name is Dr. Charles Ramos. Today I want to cover a few topics from chapters 1 and 2 of your textbook. Hopefully you've had a chance to skim through the book and pick up on some pertinent information. But this lecture is meant to highlight some of those really important topics so that we're all on the same page for this week. So to start off, let's go ahead and go through some fundamentals, starting with anatomical position and direction. So the importance of these terms comes into play when documenting and communicating with other healthcare professionals. And I'm assuming many of you that's where your career is kind of pointed towards. So when we get into anatomy, it's really important for everyone to have the same terminology. So it's just like using terms when giving someone directions or looking on a map. You can't just say up, down, left, or right. It has to be relevant to the context. So, for example, on these pictures, distal, anything going away from the midline would be considered distal, and then anything going towards the midline would be more proximal. And it all, again, depends on context. So if we're talking about the forearm, for example, you would, something going away from the elbow would be distal, something going towards the elbow would be proximal. Another example would be if, let's say, a radiologist creates an MRI report. Let's say you have an injury and now the radiologist has to report his findings and report this to the orthopedic specialist who will decide if you have surgery or not. So he needs to be pretty precise so that the specialist can give you, the patient, can well inform you and also give you the appropriate options. So let's move over here to this illustration. Let's say you've injured a meniscus, and in this case, let's say the injury happens in this area right here. So let's suppose this MRI is taking a cross section of your knee. So this is like if we were looking from the top to the bottom of your knee, looking kind of like a bird's eye view. And according to this would be the medial side, this would be the lateral side. So, if the radiologist is very vague, he could just say, well, you have a lesion on your medial meniscus, which then the specialist would know, okay, it's somewhere on this side of his knee, but exactly where. Now, if the radiologist states that the lesion occurred in the anterior medial aspect of the meniscus and that the lesion was 8 millimeters long and maybe gave a little bit more specificity as to the outer rim or the inner rim, that would allow the specialist to make a better decision because blood flow into the meniscus is very critical. So if you have a lesion closer to the inside or going across, there may not be enough blood supply to allow the patient just to heal. It may require surgery. And so that's the kind of detail that helps a physician make decisions. And hence, again, the reason for being specific about the terminology and learning the terminology, which you guys will be doing in the next few weeks. Moving on to the types of movements that the body can perform, we separate these into 3 cardinal planes of motion, which are transverse, frontal, and sagittal, as noted in your textbook. And obviously, there's movements don't strictly occur in these in these planes where there's no deviation from it. There's planes that overlap all 3 of these, but just so that we can categorize some of these movements, we created these 3 planes of motion. So, for example, you have the transverse plane of motion where you see a lot of rotation type of movements occur, as demonstrated here. So anything where you have horizontal abduction or adduction, any kind of rotation at the spine would occur in the transverse plane. Now, movements such as abduction or adduction of the shoulder, let's say abduction and adduction at the hip, those movements occur in the frontal plane. So, um, anything that kind of when you perform it, it kind of feels like a lateral movement. Any of those movements would be occurring in the frontal plane. And finally, movements such as elbow flexion, shoulder extension, hip flexion extension, anything with the head moving forward and backward, all of that occurs in the sagittal plane. Okay, moving on to the skeletal systems. We have the axial skeleton and the appendicular skeleton. And these stats right here, they're important to know just so that you can understand the amount of structure that is involved in each portion of your whole body. So axial skeleton, anything that involves the skull, the spinal column, sternum, and ribs, about 80 bones, and then appendicular, anything with the upper and lower extremities and the pelvis, includes about 126 bones. And this is actually a pretty cool, numbers to know so that you can show off in front of your friends and let them know like that you know a lot about anatomy. So that's a pretty cool perk of knowing this stuff too. Finally, it's important to note the functions of the skeletal system. Protection is a pretty obvious one, especially the axial skeleton, which helps protect a lot of vital organs. Maintaining posture, attachment points for movement, mineral storage, and a really interesting fact is hemopoiesis, which is the production of blood cells in the red bone marrow. So those are really important functions that you may have not known. And so taking care of, your bones through proper nutrition and exercise is really important for your overall health. Next, I want to discuss Wolff's and Davis's law. So first, Wolff's law states that, any demands that are placed on the bones, they will adapt to them. And the reason this is important is because as your body is developing, as babies grow up to be kids and kids into adults, all the demands that you place on the skeletal system directly affect how those bones are developed. And this concept comes into play when you have injuries. So as we're dealing with athletes that sustain fractures, as they heal, this same law applies, or this same concept applies. If we apply appropriate amounts of loads on the bones as they're healing, then we'll most likely be able to recover the bone that was lost or the bone that was damaged. However, if not enough load is placed on it, then that creates an opportunity for scar tissue to start to develop and fill in any gaps. And that's not the same as the original bone tissue, which may leave a bone much weaker. On the other hand, if we begin to put a lot of stress on the bones early on while the bone hasn't fully healed, then we're also creating an environment where there isn't good approximation by the two pieces of bone. And again, a lot of scar tissue can develop because of that. Another important point to make here is older populations begin to lose a significant amount of bone density after the age of 50, and every year they start to lose a good percentage of bone, and that rate only increases as you get older. And if you're not staying active as you're entering those older years, if you're not placing those demands on the bones, then your body isn't creating more bone tissue, and so you're constantly losing it. And in the study of gerontology, there's a lot of research showing that as older adults get into those older years, the more active and the more strength training they do, the more bone density they retain. A similar theory applies to soft tissue, which includes muscle, ligaments, and tendons. The more movement, the more demands that are placed on those tissues, the more range of motion and tension that they will keep, meaning your normal ranges of motion for hips, shoulders will more accurately mirror what the norms for most people are, and there won't be that many muscle imbalances between, let's say, your right and left shoulder or right or left hip. But someone more sedentary that doesn't use those joints, that doesn't really use those muscles, um, obviously you're going to see less hypertrophy, but you're also going to see less range of motion. And as we mentioned before, coming back from injuries, this theory becomes even more important. We have to give the damaged tissue enough time to recover. But once the, let's say, tissue healing process has taken place, it's very critical for the patient to begin placing those normal stresses on the soft tissue. Moving on to the types of joints that we find in the body, and also where to find them in the body. We have synarthroidal, amphiarthroidal, and diarthroidal, which are also called synovial joints. Synarthroidal we don't deal with too much, but those are the good examples are sutures of the cranial bones and sockets of your teeth. The amphiarthroidal are the ones that have slight movement, so syndesmosis, symphysis, and synchondrosis. Syndesmoses are held together by strong ligaments and can be found in the coracoclavicular joints, which is in the shoulder, or in the inferior tibiofibular joint, which is close to the ankle. A symphysis type of joint is separated by a fibrocartilage pad, and a good example would be the symphysis pubis, which is in your pelvis, and also the intervertebral disc in your spine. Finally, the synchondrosis type of amphiarthroidal joint is separated by hyaline cartilage and can be found in the costochondral joints that connect the ribs to the sternum. And a lot of times here, any athletes or patients that sustain direct trauma to that area many times can say that they're having trouble breathing and that they have sharp pain to palpation, and they can be confused with rib fractures, and sometimes it could just be a sprain of this synchondrosis joint. We have the synovial joints or the diarthroidal joints, and these are characterized by joints that have joint capsules that have synovial fluid that's secreted into that joint capsule, occasional ligaments that line the joint capsule, and hyaline cartilage which lines the articular surface of the bone. So all this describes pretty accurately, let's say, like a knee joint, because there is, let's say, the MCL, the ACL, all those ligaments are within the joint capsule, intra-articular. There's also synovial fluid in there, and the surfaces of the femur and the tibia are both lined with hyaline cartilage. So if a great example of a synovial joint is the knee joint. When discussing joints, it's really important to understand the concept of stability versus mobility. And there's 5 contributing factors when talking about joints. Those would be bones, cartilage, ligaments, muscles, proprioception, and motor control. And this illustration right here kind of gives you an idea of the continuum that these joints work in. The more stability you have, the less mobility you're probably going to have, and the more mobility, then the less stability. And a lot of those things are, like I mentioned, are determined by what types of bones, if there's cartilage, the number of ligaments, the strength of those ligaments, how many muscle attachments to that joint, and then finally proprioception and motor control, which we'll discuss a little bit further along in this lecture. The next topic is physiological versus accessory motions. To be more specific, osteokinematic and arthrokinematic motions. So the osteokinematic or physiological motions are the motions that we're all familiar with: flexion, extension, external rotation. But the arthrokinematic or accessory motions, spin, roll, and glide, are not very common to us, but they are necessary to perform the physiological movements. Where these really come into play, and when you really get to know these, is uh, when you begin to practice an intervention, a therapeutic intervention called joint mobilizations and proprioceptive neuromuscular facilitation, where you are tasked to passively um, perform these motions for a patient. So grabbing someone's shoulder and providing some sort of traction, and then also a movement in the direction that the patient can do by themselves. By doing that, by providing this passive or assisted type of glide, roll, or spin, let's say someone that has trouble moving their arm past 90 degrees of flexion because they have slight pain, or they have a really tight shoulder. By performing these motions for them, it will assist them in then doing an active, let's say, shoulder flexion, or being able to reach overhead on their own. Moving on to the properties of skeletal muscle. These are the properties that distinguish skeletal muscle to other soft tissues such as ligaments, tendons, um, any type of cartilage. So excitability, contractility, extensibility, and elasticity. So one of the main ones is excitability. So the the ability for a neural impulse to make a muscle contract is very unique. There's, ligaments, tendons, they can't do that. That only happens in the skeletal muscle. And similarly, cardiac muscle or smooth muscle, um, they're not muscles that you can directly control. Only skeletal muscle is that type of tissue that can be activated by a neural impulse. Okay, moving on to other muscle terminology, origins and insertions. So just so that we're all on the same page, origins, um, more structurally known, is the more proximal uh, uh, portion of the anatomy that we're dealing with. Um, and the insertion is a more distal. Um, and then the other way to describe it is the the anatomical landmark that moves the least would be considered the origin. The one that moves the most would be the insertion. So, for example, we have the biceps brachii here, where the origin is more um, proximal, so it's closer to the midline, on the close to the humeral head here, and the insertion or the attachment would be on the ulna. When this muscle contracts, the humerus doesn't move towards the ulnus. The ulna, I'm sorry, moves towards the humerus. Or, for example, if we're looking at the rectus femoris, one of the quadriceps muscle, the origin is in the anterior inferior iliac spine, and the insertion is in the tibial tuberosity, so it attaches down at the tibia. When it contracts, the um, the anterior inferior iliac spine of the pelvis doesn't move towards the tibia. The tibia is the one that moves upwards. Next, we have different types of muscle actions. Previously, or in other textbooks, you might see muscle contractions, and that term is used a little bit less just because contraction kind of gives you the idea that the muscle is shortening, or the muscle has to shorten for there to be an action. But when we get more specific about it, it's more of an action. And we have two main ones, which is isometric and isotonic. Isometric type of muscle action, the muscle fibers are shortening or are they're trying to contract, but there is no shortening of the muscle. It stays stagnant. So think of, if you have your arm against the wall and you try to push against the wall, there's, you're actually tightening that muscle up, but there really is no movement of the joint. Isotonic refers to contraction of the muscle, but it requires movement as well. And there's two different movements that can occur. One is concentric and the other is eccentric. Concentric is the typical movement that we know where the muscle is shortening. So in this case, the biceps is pulling the ulna towards the humerus. Eccentric contractions can be a little bit more difficult to understand. There's still contraction of the muscle. However, the weight or the force that is being applied distally is overpowering the force produced by the muscle. And overpowering may not be the correct term, because in this case you could just be lowering the weight down. So it's not like it's overpowering you, but it's a controlled lengthening of the muscle. And during this period, there's still muscle fibers contracting, but the whole muscle is actually lengthening. Finally, we'll talk about proprioception and kinesthesis, where kinesthesis is more of the conscious awareness of position and movement of the body in space. Proprioception is the unconscious awareness of this, where you rely on different organs and the other parts of the body that give you feedback to know where you are in space without really having to think about it. So delving a little bit more into proprioception, there are different parts that are involved in this. A few of them you may have read in your textbook, such as muscle spindles, Golgi tendon organs, which are within the muscle, and then other properties which are within the skin. For example, Meissner's corpuscles, Ruffini's corpuscles, and all of these are within the joint and the skin. All these give you feedback on, how much weight is being applied to that joint, where it is in space. For example, if you step on an unstable surface and you have to catch your balance, a lot of these factors are working instantly. You don't really have to think about it. Now, when you injure yourself, all of these systems become disrupted, and it takes time to kind of retrain them and regain that control. And therefore, a lot of balance exercises are performed where you don't just deal with the strength and the range of motion, you're also having to retrain a lot of the balance and spatial awareness of the athlete. So when dealing with injuries, it's really important to take into account proprioception, kinesthesis. When rehabbing a patient, it's not just about reducing swelling and reducing pain, regaining strength and range of motion. It's also really important to address the loss of all these systems. So it's really important to incorporate that into the rehabilitation program early on, as we'll know that the athlete will not be able to return to their sport if they're not fully ready to compete and able to trust the joint or whatever body part they've injured. So I'll stop there, and a lot of the other information, obviously, you're going to read in your textbook. But if there's any topic, anything that didn't really make sense that you want me to further elaborate on, please email me or give me a call. Reach out to me. I'll try to explain it as best as possible, and I'm just trying to give you guys a lot of the highlights of what's very relevant when it comes to dealing with allied healthcare and dealing with patients. But if there's any other topic that you guys want me to elaborate on, please reach out to me. So that's all I have for you today. Good luck on all your assignments. If you have questions about that, also, you can reach out to me. So thank you guys. Have a great week, and I will see you next week.